Hi there, I'm Helen Taylor, the lead cyberknife radiographer at the Royal Marsden Hospital in the UK. I've been in post for 10 years now, starting out at our site in London when we installed our VSI in 2011. We've now treated over 3,000 patients in the public and private sector, and our second cyberknife was installed at our Sutton site, which is on the edge of London, in December 2019. It was commissioned and ready for a go-live in April 2020, but the COVID pandemic put that on hold, and we had a very low-key start later that year in July of 2020. Our patient numbers built slowly over the year due to the pandemic, starting with a transfer of some of our radiosurgery workload, which covers a huge geographic region, and enabled these patients to have shorter travelling distances, and more importantly, not to go into London at a time when they were very reluctant to do so. X-site spine tracking for spine and nodal sites soon followed, along with prostate cases, some in the PACE-C study, which is led by the Royal Marsden. In June 2021, we had new covers fitted, so now we're a sleek and shiny S7. In this photo, you can see our radiosurgery team, the radiographers, physics planners, and consultant oncologists in front of the S7. So we've been using Volo optimization in preference to sequential planning for some time now with the VSI. We jumped straight into using this when we had our new robot. We saw definite improvements in both time to plan and treatment times. And on top of this, we had the MLC option. Initially, we did some comparison plans, but soon fine-tuned what suited the MLC and what didn't. A small evaluation of this double planning in our first 6 months saw approximately 10 to 20 minutes shaved off each fraction. So as you'll see in the examples that I will show, there are some clear reductions in treatment time in all body sites. Most improvements have been seen in irregular shapes or larger volumes where the MLC seems best suited. The size at which we consider using MLC in preference to iris is about a diameter of 2 centimeters, which fits nicely with the Accuray recommendations. After a year of using the MLC collimator, we now feel well established with this technology and have started to cut down on the number of patient-specific QA plan checks we do each week. We now do 1 plan check per week, rotating through iris, fixed, and MLC collimator plans. Anything that fails the RadCalc second check or differs from standard practice will also get QA. As well as planning differences, we have the new shape and size of the MLC head itself, which is as wide as the robot head, but short front to back, unlike the VSI. The beauty of the symmetrical positioning of the robot in the room has led to changes in our assumptions about what can be treated head first or feet first. And based on this, we've changed up some of our immobilization equipment. Concerns about collisions or close passes for those node and beam positions with the VSI are now a thing of the past on the S7. We've implemented using the CombiFix feet and ankle immobilization for prostate and pelvic cases, and this maintains continuity throughout the entire radiotherapy department. In the past, this would have been an issue due to the robot arm reaching over the patient's feet and coming very close to any immobilization used. We tended to use a vac bag around the feet and ankles for many years, and this meant it could be adjusted and remolded on treatment if necessary. But now on the S7, this is no longer necessary. We also don't have concerns about very lateralized lesions, for example, lateral liver lesions or very offset pelvic nodal sites, as the S7 robot doesn't need to stretch right over the patient's body from one side to the other. What we do have is the manual change of fixed collimators, and we actually use quite a lot of them in our radiosurgery service. We target quite a lot of micromets, so unfortunately the 5 and 7.5 millimeter collimators are coming on and off all day, but that keeps us fit, and that's just our practice. Finally, for the new S7, we're integrated with Mosaic, which is a change from a standalone unit. Following a recent software upgrade, we're now on IDMS 3 and Windows 10, and the integration feels complete. The connection and disconnection times following treatments are now instantaneous. So let's go through some examples of treatments planned with the MLC, and I'll show you the benefits of this sleek and beautifully integrated innovation. First, we'll look at a prostate case, then an example of spine tracking, and then an SRS case using 6D skull tracking. In this image, you see the plan for a 74-year-old male with a Gleason 3+4 prostate cancer who presented with a PSA of 8.7. So that's categorized as intermediate risk. He was started on androgen deprivation therapy for 6 months to be followed by radiotherapy. He agreed to be part of the PACE-C trial and was randomized to 5 fractions of SBRT in that study. He was planned with fiducial insertion for tracking and MRI image fusion, and he completed treatment in June of 2021. Of note, PACE is an international multi-center phase 3 trial comparing SBRT and standard fractionation led by the Royal Marsden. The SBRT dose in the study is 36.25 gray in 5 fractions. The slide on the left here shows, this is the hedgehog plot or beam arrangement, and on the right we've got the beam's eye view of one of the MLC fields. You can see that they're both demonstrating very nicely how the beams are coming in and avoiding the rectum and the bladder. You can see the rectum as an OAR in orange, the bladder is in purple, blue and green are the femoral heads, in slightly darker green is some small bowel that's been contoured, and the PTV itself is in magenta, where all the beams are targeted. As well as being a good quality plan, the MLC option for this patient gave us a very short delivery time of 23 minutes. This is a huge advance for patients having their prostate treated. Typically, treatment times for us prior to Volo implementation were in the region of 45 to 50 minutes. This then dropped down to about 35 to 40 minutes with Volo, and now an SBRT prostate treatment with on the S7 with MLC is delivered in less than 25 minutes on a regular basis. For those with reduced bladder control, this is crucial in maintaining their dignity and self-respect throughout their hospital visits and treatment, and for the accuracy of the treatment delivery, which can be affected if a long treatment becomes even more protracted. So let's go through the plan now, and I'll talk you through the dose constraints for the PACE trial. So starting with the rectum, the V18.1 gray should be less than 50%, which you can see very nicely. V29 gray, less than 20%, and again, we've achieved that. And the V36 gray should be treating less than 1 cc, which we've managed. Looking at the bladder constraints, V18.1 gray should be less than 40%, and the V37 gray less than 10 cc's. That's our mandatory target, but we're always aiming for less than 5 cc's, which again, we've achieved with this plan. The prescription dose that we're aiming is for the GTV to be covered by the V40 gray more than 95%, and the PTV 36.25 gray covered by 95%. So in this second example, the patient is a 48-year-old female who was diagnosed with grade 2 left-sided breast cancer, ER/PR positive, HER2 negative. She had radiotherapy to her chest wall, IMC, and supraclav fossa following surgery, and then continued on tamoxifen as standard. 3 years later, she was diagnosed with oligometastatic disease with a solitary lesion at L1. The key thing with this treatment plan was comfort and speed due to her back pain. And again, we've come out with a nice short treatment time of 32 minutes to deliver a dose of 27 gray in 3 fractions. And this is a standard dose in the UK under our SABRE consortium guidelines. In the image on the left, you see a zoomed up version of the plan with the percentage isodose curves on, and you can see the fingers of 10% dose going through the liver and small bowel, which is perfectly acceptable, and with the fields neatly sliding in between the kidneys. In the image on the right, again, you can see that very nicely demonstrated. The MLC leaves are avoiding the kidneys and also the spinal cord. Our spinal cord tolerances are based around a planning organ at risk volume, or PRV, which is the spinal cord plus 2 millimeters. And this again is using the UK SABRE consortium guidelines. The 18 gray Dmax for less than 0.1 cc and 12.3 gray Dmax for 1 cc were both well achieved using this technique. The maximum volume of both kidneys for this patient was approximately 350 cc, and our dose constraint for a 3 fraction plan is that not more than 200 cc's should be getting 16 gray. In this case, 0.75 cc was getting 16 gray. Here, as part of the planning process, the physicist is reviewing the plan and looking to further optimize by minimizing the number of really small fields, and I've highlighted one here. This will make for a longer treatment time and would be slightly less robust because it would be subject to small movements and would also be a very complex plan to check. So the end result for this plan was a comfortable position for the patient and a treatment time of 32 minutes per fraction. From my experience going back 10 years, most plans done for spinal lesions using Excite spine tracking and an iris collimator on the VSI have been in the region of 40 to 50 minutes. And so now being able to use Volo and MLC on the S7 is a huge step forward for the patient experience. The patient completed treatment at the end of May 2021 and is now back in the hands of her local team for follow-up. In this final example, a 57-year-old male had surgery and chemotherapy for a distal esophageal cancer, but sadly 1 year later developed a solitary hemorrhagic metastasis, and this was in the cerebellar vermis. Due to its size and location, this was treated with our 3-fraction protocol, delivering 24 Gray, and perfectly suited the use of MLC. We did do a plan comparison. So on the left here, you can see the MLC plan, and on the right, the iris version. Here in the second slide, the iris plan is labeled as R for reference. The critical organs that were contoured and in priority order are the optic chiasm, the nerves, both cochlea, the brainstem, normal brain minus the PTV, and the eyes. In this case, the brainstem tolerance is at its limit due to the location of the lesion, the constraint being 23.1 Gray Dmax. What you can see in this dose statistics table is we've got the same plan quality and there are no disadvantages with the MLC plan. And this is often what you find when comparing iris and MLC plan options, that the conformality index and GTV coverage, which I've highlighted in purple, are equivalent, and there are no other shortcomings in the MLC plan. The maximum dose in the MLC plan, however, is lower, and I will go on to explain the relevance of that, and I've outlined that in red. What we do have are key savings in daily treatment time and overall monitor units, again highlighted in purple. For any patient who's having treatment in a shell, a saving of 9 minutes per day is highly significant. What you can see in red is the max dose is lower in the MLC plan, as it is prescribed to a higher isodose curve, meaning the coverage is less peaked across the volume. There's no evidence to suggest a reduced max dose within the target has any impact on clinical volume. Generally, for fixed and iris collimators, a prescription isodose line close to 50% gives the sharpest dose fall off, which is achieved, as you can see, in the iris plan. But for MLC, it's different. Here, the good coverage, and the conformality index was 1.04, can be achieved easily with less beam numbers because of the much more conformal MLC shapes. In most beam directions, the MLCs open up such that the apertures see the whole 2D projections of the target in most cases. This results in a flatter dose distribution compared to distributions from other collimators, and sharp dose fall-off can still be achieved outside the target. As a result, the prescription isodose line can be selected much closer to the maximum. In the case of the MLC plan, it's 74.9% of the maximum. That's 24 Gray over 32 Gray max, compared to the iris case, which is 24 Gray over 41 Gray max. The beams required in the MLC plan was a total of 54 segments in 49 beams, compared to the iris case with 146 beams. Hope this has been a useful introduction to a few planning examples using Volo and MLC for those who are new to CyberKnife, and has sparked some discussion amongst those who've been using CyberKnife for years. The aim for this short presentation was to demonstrate the key features of the S7 and why we believe it is such a good choice for our clinic. The Royal Marsden has 11 linear accelerators, an MR Linac, a brachy service. We treat pediatrics and TBIs, and we now have 2 CyberKnife units. We believe in having every option available for our patients. We always want to be at the cutting edge of technology and in using the multidisciplinary team methodology to decide on what's the optimal approach for each individual. Our patients travel from around the world to benefit from experts in their fields and for technology that is designed with the patient first. This is what we get with the Accuray CyberKnife. My thanks go to all the members of the CyberKnife units at the Sutton and Chelsea sites of the Royal Marsden. This has been a perfect example of teamwork, getting the unit up and running during the pandemic, sharing our learning remotely and in person, and developing skills and knowledge throughout. This presentation has also been a team effort, so many thanks to all involved. And once again, thanks go to the Royal Marsden Charity for funding a first and now a second CyberKnife for all our patients. If you have any questions or queries, please do get in touch via email. Thank you.